to ECMO Society of India yearly annual conference, of course. And it's really heartening that we all in India have grown from merely 2 or 3 centers doing ECMO to more than 34 centers doing ECMO now. So maybe the number is more. I'm aware of 34, maybe the number is more. And each one of you go back to your institution to learn not just ECMO for yourself and your patient, but also to teach it to more. And it is our endeavor from the ECMO Society of India to make you all come together. I'll speak about it at the end of my talk here. But it is ECMO from AIMS, the veno-arterial type, as Dr. Vivek has been talking about in the previous talk, coming to you primarily from the use of the bleeding point of view. And I would be talking about the thromboelastogram, which we have been using in plenty in the confines, not just for ECMO, but for most of our post-operative bleeding patient. So we all know that point of care viscoelastic measure of thromboelastography fits into our normal armamentarium of coagulation monitoring, and it gives us so much more information, not just for a bleeding patient, but also particularly for ECMO. And in fact, ECMO and anticoagulation is a very, very in thing. It is something which most of the new societies of transfusion are banking upon. In fact, the era today is that of comparing which is the best marker for giving you a point of care testing, whether you use a FFP or a PC in the developing country like us, or you use a prothrombin complex concentrate in a developed countries like Germany or Europe or USA. So thromboelastography is measuring the thrombodynamic properties of blood as it is induced to form a clot under a low shear environment resembling a sluggish venous flow. The patterns of change in shear elasticity enable the determination of the kinetics of this clot formation and growth, as well as the strength and stability of the clot formed. So it just means that as the clot is forming in the extrinsic and the intrinsic pathway and meeting in the common pathway, you have the formation of a platelet fibrin, all of them aggregating together to give the clot a stability. That clot stability is converting on various modules by different systems made by different people in the form of a signature curve. And thromboelastography signature curve we'll be talking about in detail. So thromboelastogram, unlike an APTT or an INR or a platelet count, assesses the speed of this clot formation. It assesses the potential for the availability of a hypercoagulable or a hyperfibrinolysis state. It assesses the accelerated clot breakdown of fibrinolysis. It assesses the clot strength. Basically, how good is the clot to prevent that bleeding with your anticoagulants like heparin, to which your patient of ECMO is faced with. And it is also tells us about the partial assessment of the components of clotting process, that is platelets and coagulation factor. So that with the coming up of TEG or sonoclot or ROTEM, you don't need to rush for a lab test for APTT or platelet count on your patient. So thromboelastogram is a functional assay for a global assessment, and what it does best is tells you about factor deficiencies, tells you about the fibrinogen function. In fact, most of your bleeding patients have a hypofibrinogenemia. So this hypofibrinogenemia is detected within 5 minutes, let's say on a ROTEM by a marker called FIB10, on a TEG by so many factors like the R time and the K time. So within 5 to 10 minutes, you're coming to know what is the problem with your patient while the patient is on heparin. So the platelet function, the fibrinogen levels, the clot strength, and the lysis of the clot is what the thromboelastogram is telling us about. So we all know that between thrombosis and bleeding, particularly in cardiac surgery and in ECMO, or even in a VV ECMO, or wherever we use in a cath lab any antiplatelet drug, there is always a struggle. There's a balance between thrombosis and bleeding trying to be put up by most of us physicians. The basic principle in a thromboelastogram is that here you have a cup, a cuvette, in which this is the electromagnetic field. You can see the north and south pole. This is the electromagnetic transducer here. You put your patient's 0.36 or 0.4 ml of blood in this cup, and this blood in this electromagnetic field is moved upon by a piston which works on the electromagnetic transducer. So this pin is suspended by a torsion wire, and the moment this wire or piston moves into the blood, there is a coupling motion of the cup to the pin. Now, in the case of rotum, this cup is fixed. In the case of TEG, this pin and cup move together in a coupling motion, and this increases the tension in the wire, which is detected in the form of a signature by the electromagnetic field. So this is a viscoelastic property which is developed. So we know that when we use ECMO or we use ventricular assist devices, even IBP or trauma or any drugs that the patient is on, such as group 2B3A inhibitors, stenting, any kind of DVT, any kind of smoking patient, your patient is bound to be bleeding. And to detect that bleeding and to know which exact blood product to give or what exactly to give so that the bleeding is closed immediately without resorting to surgery is what the function of a thromboelastogram or a sonoclot or a rotum is. So you have TEG, which uses in that cuvette various accelerators or various actifying agents or modifiers. These could be cellite, these could be aprotenin, it could be kaolin, it could be tissue factor. Sonoclot uses a tissue factor. The moment you have your patient on heparin, the tissue factor gets converted into a heparinase. So you're using heparinase. Some of the cuvettes aligned with abscessimab, which is ReoPro. Some of them may be containing platelet mapping reagents. So you have your cath lab patients who are on aspirin or clopid, or your CABG or ECMO patients who are on antiplatelet drugs coming to you, and you know which cuvette to use. Every company gives you a separate cuvette. It is your duty to ask from the company, my patient is on group 2B3A ReoPro. What should I be using? He will give you a ReoPro and abscessimab cuvette. So that's what the cuvettes are. There are different types. What is in ECMO, you will be using a heparinase cuvette or a heparinase cup, as the rotum cup is called. Now, how do we know where we are? The balance keeps tilting. It is the duty of the TEG, which measures the entire extrinsic, the intrinsic as well as the common pathway, and tells you about the strength of the clot and the stability of the clot. This is the machine. You can see this is the TEG machine. It has undergone many changes. 2017, a new TEG has come with rapid TEG, which measures fibrinogen levels, but it could be a single or a dual chamber. All TEG machines, unlike sonoclot, are always dual chamber. So you have two cuvettes here. This is the slot. This is where the electromagnetic field works. The newer machines have this as a bigger framework. The screen is bigger. And you have this small torsion cup. This is a cup and that's the wire. And this is how it moves up and down. You can see the movement up and down. So this is an up movement. This is a down movement. There is a heating inside the this cup slot. And there is a sensor which detects the heat, the filament and the blood and gets it converted into the electromagnetic field. It moves between 4 degrees, 45 minutes, about up to 5 degrees is the movement in the electromagnetic field of this cup and the pin. So that's how it moves. And this is the kind of signature curve that you get. Now this signature curve is very important. This is something that you must learn and you must know. This is how it begins. So when your clot starts forming, this is your R time. And this R time along with the K time is telling you we'll deal with this, all of them. Then the angle begins. This angle is normally an acute angle. This is the alpha angle. And as the alpha angle begins, it tends to branch out. This means the clot is now stabilizing. And this is your MA or maximum amplitude. And this starts lysing at 30 minutes and at 60 minutes. So R time, K time, alpha angle and MA. And lysis at 30 and lysis at 60. We'll go about it one by one and that's how it forms. So this is your R time, the beginning, then your K time. So between R, K and alpha angle and the formation of the maximum amplitude is your thrombosis. Then once the clot has formed and it has stabilized, it starts lysis. And this is when your fibrinolysis happens. So the R time represents the period from the initial start to the beginning of the fibrin formations. That is the clot strengthening. And it measures the normal clotting studies, 15 to 23 minutes in a native blood and 5 to 7 minutes when you use kaolin activated blood. So your cup, if it contains kaolin, within 5 to 7 minutes you get an R time reading. So that's our normal range, and 5 to 7 minutes is what the R time should normally be. So when does R time increase? Whenever you have a factor deficiency, an anticoagulated patients like on heparin, a severe hypofibrinogenemia, which means your fibrinogen levels are low, and a severe thrombocytopenia. So it means your platelet is low. So when I say platelets are low, it means my patient needs any one of you? It needs platelet concentrates, or it needs a prothrombin platelet prothrombin complex. If my fibrinogen is less, however much of platelets you give, the patient will not stop bleeding. This patient will only respond to fibrinogen. And where do you get fibrinogen? You get fibrinogen in? Pardon? Cryo. So this patient will not respond to PCs. This patient will not respond to any amount of surgical treatment, because your patient will come back again and again, because in this patient the fibrinogen is low. So within 5 to 7 minutes, you have come to know that your patient is bleeding, the R time is increased. And if the R time is decreased, it means your patient is uremic. It is hypercoagulable. So this is what you must remember. These are the 5 general conditions. Whenever your patient's dehydrated, whenever the urea, what happens in ECMO? The renal dysfunction starts. And the moment the renal dysfunction starts, what will happen? The moment the renal dysfunction will start, the hypercoagulable state will happen, and the R time will be less than 5 minutes. So a hypercoagulable state, the R time is shortened. So this is the beginning of the renal dysfunction. The K time is an onslaught or the continuation of the R time. The K time represents the time taken to achieve the clot strength to up to 90% stability, and it equates to an amplitude of 20 millimeters, 1 to 3 minutes in kaolin activated, and 5 to 10 minutes in native blood if you're not using kaolin. This is the normal K time value, and again it is decreased in hypercoagulable states, and it is increased in any factor deficiency. Now liver function failure happens on prolonged usage of ECMO. When hepatic and renal failure or hematorenal shutdown happens, your K time and your R time would be shortened. So your 2, 5, 7, 9 and 10 factors would be deranged. And whenever these factors are deranged, your R and K time would be less. So thrombocytopenia, when your platelets is less, thrombocytopathy, when your platelets, remember ECMO is a partial cardiopulmonary bypass. So your platelets are getting sludged along with the RBC. So not only will there be hemolysis, there will be platelet dysfunction and platelet thrombocytopathy. And there will be a hypofibrinogenemia, because fibrinogen, which factor is fibrinogen? 1 or 2? Sure? How many for 1 and how many for 2? 1. It is 1. Okay. So now if I turn that side, I can't, the mic is not working. So alpha angle measures the rapidity of the fibrin buildup. So once the clot is stable with the platelet aggregation, the fibrin starts building up and cross-linking and clot strengthening happens. Normal is 22 to 38 minutes and 53 to 67 minutes in cases of, 53 to 67, the alpha angle becomes more obtuse in cases of kaolin activation. So normal, you must remember, this is an MCQ question for most of your thing, is up to 38 minutes. Anything between 20 to 40 is also normal. So when you have alpha angle increasing now, it is hypercoagulable, and a decrease happens, the reverse of R and K in thrombocytopenia and decreased fibrinogen. So maximum amplitude, 80% platelets and 20% fibrinogen is what the platelet function is. If you see what happens, the MA is a direct function of the maximum dynamic properties of fibrin and platelet bonding via group 2B3A and represents the final fibrin strength of the ECMO process. It correlates to 80% platelets and 20% fibrinogen. So when you have a stable clot, the stability is due to 80% platelets, 20% is fibrin. And the normal range of MA is between 45 to 55 is the way I remember it. But more than 12.5 millimeters is in Rio Pro blood, and between 59 to 68 is in kaolin activated blood. So whatever cuvette you are using, that cuvette, that pamphlet will give you the normal readings, and I'll show you the signatures. Normal readings come along with their patient's reading in all the TEG curves. So MA is increase in hypercoagulable states, and it is decrease in the reverse, that is thrombocytopenia, thrombocytopathy, and hypofibrinogenemia. So please note, when you're talking of a fibrin strand or a clot strength, which is platelets and fibrin, and platelets and fibrinogen, the increase and decrease of platelets and fibrinogen is together. And to market this TEG, the ROTEM came up better. We'll talk about it. They started to put INTEM and FIBTEM together, and these became the best markers. So this is how they scored over TEG. So this is how, as I was saying, the normal old classical TEG looks like. There is a fibrinolysis here. If you can see, there is a fibrinolysis here. It is, instead, this is the normal, it is getting shortcut small, and then there's a big line. So the MA is also incomplete. You can see the K time is 2.8, though that is normal. The alpha angle is also near normal, but the MA is small. It is 28.8, much less than 55. And then you have your EPL and lysis 30 happening much earlier. So this is a patient with hyperfibrinolysis setting in. So this is one such example. The other is you must have a quantitative analysis. You must know the RK and the alpha angle. You must know the MA at 60 minutes, the amplitude at 60 minutes, and then the lysis at 30 and the lysis at 60 is what you know. So that means in 1 minute time and up to an hour's time, you have a complete 60 minutes time. You have a complete setup of what would come. And this is the major coagulation and fibrinolysis, which go hand in hand. You have the thrombosis or coagulation R time. So you get an MCQ. What factors tell you about hyperfibrinolysis? R, K, alpha, or L30? What would you mark? L30. So that's how you come to know that for R, K, and alpha angle and MA, it is coagulation or thrombosis. And once fibrinolysis or clot retraction happens, it is a lysis 30 or a lysis 60. So you must be very familiar with this entire setup. And lysis at 30 minutes will be seen in 0 to 8%. You must know this is better than the first one. When you see a maximum clot strength, you must know it is platelets and fibrinogen. And if this is less, the first thing you give is fibrinogen or cryo and then platelets. Sometimes cryo alone is not sufficient. There is a decrease of both fibrinogen and platelets. But if you've given cryo and you've given platelets and your patient is still bleeding, it means there is hyperfibrinolysis. At that time, go in for lysis 30, wait till 30 minutes, wait till 60 minutes. If it is happening far too early, it means your fibrin is getting eaten up. It is a state of consumptive coagulopathy. Your patient's heading for a DIC kind of a picture. And in that case, it's not just fibrinogen or platelets, or not just cryo, but it's FFP as well. So you may need to give not just 2, 3, or 4 units. You'll need to give a whole gamut of maybe 30, 40 units. We recently had a patient who had a CABG, went on ECMO, couldn't wean off from the bypass, weaned him off ECMO, he became all right, bled on the 4th day in the ward, extubated patient, brought back to the ICU, bleeding and bleeding, gave 30 units of everything, patient became all right. Second post-op day after becoming all right, there's a secondary DIC. And here the fibrinogen was less. So we had to give prothrombin complex concentrate and the patient octaplex we gave and the patient became better. So those are the kind of signature curves that come up in different states. These are normal, that's the normal one that you're seeing. That is when you have a factor VIII deficiency. Here you can see the R and the K are prolonged, MA angle is and the alpha angle are decreased, and everything is on the smaller side. Here the R is normal, the K is prolonged, R is finishing here, but the K is prolonged and your MA is decreased. So this is a platelet blocker. This is a thrombocytopenia. This patient needs no FFP, no cryo, only platelet concentrates. Okay, then this is a patient with fibrinolysis. Here the R is normal, the K is normal, but the MA is decreasing, tapering off fast. Lysis 30 is increased to more than 7.5 or up to 10%. And this patient will need what? Fibrinogen. Only fibrinogen, only cryo. Give 4 units of cryo, this patient will become all right. Or you give a fibrinogen concentrate. And this is a hypercoagulable dehydrated patient where the R and K are very small and your MA and alpha angle are increased. This is a typical case who comes to us in a fasting state, a dehydrated patient or a uremic patient or a patient on ECMO. This will be the picture most commonly seen. And if you continue on ECMO and ECMO is not helping the patient much, this is the picture you will see. So when you have your patient coming in on ECMO, remember these two figures. These are the most common figures. If you have this figure, it means it is ready to be weaned off ECMO. Okay, so those are the 3 figures there. When you do a TEG versus conventional tests like APTT, PT, INR kind of study, then they are more in touch with the current concepts of coagulation, which the British Transfusion Society and the American Transfusion Society have laid down. It gives assessment of platelet function. These are dynamic tests. They tell you within a short period of time, and they do not delay your giving of your blood products judiciously. They are cost effective. So one may think that TEG, Rotem, Sonoclot are so expensive, I use them. My system doesn't have it. But the moment you give more blood products, it becomes just as costly, and you may, because awaiting those lab reports which take time, you may lose your patient and you may end up spending more on the patient with so much bigger gamut of blood products. So advantages of TEG are many over the best ones. I would say after doing 3 research projects on them, it is one of the most cost effective compared to the conventional tests of waiting for APTT. In our center, we are not doing APTT anymore unless or until these are redo surgeries coming and the patient continues to bleed, then we correlate. But we're using Sonoclot very, very judiciously. Thromboelastography may have a role in non-cardiac PA on ECMO because patients on ECMO are all the time bleeding. And why do these patients bleed? Because these patients are on a heparin transfusion. How is bleeding managed in these patients? These are some things that TEG resorts to. I'm talking so much about this because last 1.5 years we've been using, in fact, one of our machines is permanently kept as a research project in the form of a Rotem, which is a modified TEG in one of the OTs where we do most of our tests on patients who bleed. So why do patients bleed? There are so many ECMO factors, there are post-ECMO factors, and surgical bleeding because of cannula malpositioning and so many other causes is one. I'll cut this short, but this was one such things to tell you. So post-operative bleeding, you know the antiplatelet effects of aspirin or clopid. You have Riopro, abscessimab, which are anti-group 2B3A agents. Your patients could be on warfarin orally or on heparin while during the ECMO is on. And pre-existing clotting factors, none of us check. Very few people will check what is the status of all the 9 or 10 pre-operative levels of the coagulation factors. Well, while you put your patient on ECMO, you'll just do a PT, APTT, and INR and say your patient's fit to go on an ECMO. Without realizing your patient's on aspirin, clopid, your patient is already, he's coming to you, especially on a VA ECMO, with a heart failure scenario. Most of these drugs cause a thrombocytopenia and a thrombocytopathy. Most of these drugs, patients who are on heart failure have a sluggish blood flow. And because of the sluggish heart blood flow, the moment you put these patients on ECMO, there is not only hypothermia, but stasis of blood in the LV. And this stasis of blood in the LV will give rise to clots. So doing point of care testing helps a lot in all this dynamic scenario of ECMO. So heparin effect, alien surface effect, and decreased platelet counts, which happens the moment you expose your patient to an artificial set. So how do we, what do we normally do? We ask the surgeon to keep putting more stitches at all places. We keep giving more protamine. We rely more on antifibrinolytics like tranexamic acid or epsilon aminocaproic acid. In the previous days, it used to be a proteinin. Give more platelets, give more FFP. Coagulation factor crash packs are maintained in some ICUs, give more blood and more protamine, and this entire vicious cycle of trying to put the patient with so many blood products inside him that the patient ends up with a trolley kind of a situation. So once something like that happens, we know that with ECMO something like this will come up. It is important to buy an ECMO machine and buy a point of care testing machine. Your sonoclot costs 6 lakhs. Your tech machine is there for something like 14 to 15 lakhs. And your rotum comes for 25 lakhs. So whatever your institution protocol is, I go and tell everyone, do not buy an ECMO machine without buying a point of care and an echo machine. Your patient will do very, very well. Pediatrics Department of PGI Chandigarh has just done that, and they are reveling in it. It is a 3-in-1 component where the patient's entire blood scenario as well as the echo telling you about the patient's window of the heart and how the ECMO is behaving in that 4 to 5 days when your patient is so critically ill. So damage ineffective platelets, fibrinolysis, TEG or rotum or sonoclot helps and helps and helps. Especially tells you about fibrinolysis. Fibrinogen, if given at the right time, is the best treatment for an ECMO patient. And for that, FIPTIM is one of the best tests done. We proved it in our publications. And TEG fits in very, very beautifully. And this is an algorithm that we follow. This is your common pathway. We are all aware of it. Your extrinsic platelet activation, your intrinsic, the intrinsic platelet aggregation and the activation, the extrinsic coming up with factor 8 and tissue factor and calcium coming in to activate factor 10 or the Hegman factor, and 10A then forms the common pathway. So at all 3 levels, whether there is a decrease in the platelets or an incomplete clot strength in the form of an MA, or factor 8 when there is hypofibrinolysis by L/30 coming up faster, or there is a common pathway of fibrinogen or a hypofibrinogenemia coming on with an R, K or alpha angle, all is very well taught on a point of care test. So it gives us dynamic information, and fibrin mesh with platelets, once they form an R, K and alpha normal, you can breathe a sigh of relief. This is how, if you can notice, this is how these values come on at the base. So R here is 5.8 and your normal is 12 to 26. Your alpha angle is 63.7 and your normal is 14 to 45. So in a minute you know that this patient has a very obtuse alpha angle, and if the alpha angle is increased, what would happen? Neeraj, what would happen? Yes, so your patient would be more prone to bleeding. So this is how you see your 3 patients. This is a hypocoagulable state where everything is decreased. Here is a hypercoagulable state, much, much more. And this is once you give electrolytes or fluid to this patient and you improve your ECMO flows, this patient comes down to almost near normal, till it comes to near normal. So a hypocoagulable state, renal dysfunction setting in, and a hyperthrombotic coagulable state, you must be able to tell very well. So why thromboelastography has now moved into thromboelastometry. So they have upgraded their software. The software gives you even better information within 5 minutes. You don't even have to wait till the 10th minute. And target directed transfusions are the norm. It tells you the new software, which is just coupled with rapid tech. It gives you one level, that is the fibrinogen level. It is called FLEV. And we are doing research at our level. We are comparing fibrinogen and FIPTIM and FLEV with rapid tech. And we are finding that FLEV, it tells you, gives so much of fibrinogen. The amount of fibrinogen to be given is also coming onto the screen. So that's how dynamic it has become. And definitely if you have a computerized machine over and above, even a technician can do it and give fibrinogen to your patients. Once your quantity of fibrinogen is known and you see the effect on your continuing signature curve of either rotum or TEG, then obviously the cost effectiveness of the machine comes in. So TEM or rotum measures the interaction. So far we were doing that the extrinsic, the intrinsic and the common pathway is being measured. But now the interaction of the inhibitors, which are contained even in the cups, the cuvettes, the tissue factor, that interaction is being measured in thromboelastometry, and that is how you're getting even faster results. And ROTEM is an advancement over TEG. Most centers now are buying ROTEM or a rapid TEG. The classical TEG, which I've just described to you, is there only for those who cannot afford it. And this is the ROTEM Delta, which has come in. You have this is the classical TEG. You have, can you see, instead of these two, you now have 4 cups. These 4 cups can be used for different reagents. Here you were putting the blood and there was a torsion buyer. Here you have bottle colored reagents. Like this gray one is for hepten. This blue one is for tissue factor. The red one is for aptem when you're using aprotinin. So if your patient is having hyperfibrinolysis, you will put in a test called aptem. And this is for your extrinsic pathway. So these are the 4 tests. These are the 4 cups. If you can see here, the cup is moving up and down in this 5 degrees field. Here the cup is stationary. So what do? You take with the help of a pipette. There's a very, very strong pipette. You take these cuvettes, you put the cuvettes with the reagent in the pipette, and you take it in your blue tubes, and you mix the two and you attach it to this cup, and you fix, these cups are fixed. The moment the reagent with the patient's blood is mixed and attached to the 4 cups, you get these 4 signature curves. So this is your XTEM, this is your INTEM, this is your FIPTEM, the fifth one, the pink one. Then you have an aptem, and when you use tranexamic acid, if you're using that, you have a traptem. So you can use different reagents. These are the reagents according to what you are giving to your patient and have a result given to you in 5 minutes. And this is how it comes on. So this is the ROTEM Delta. As I said, this moves and this does not move. Here you have the cuvette with the blood and you have the fibrin strands all formed in. There is again a electromagnetic field, but it is all stationary, and from here there is a light source from which this light source is detecting through the electromagnetic waves in a detector which is attached here. There is a kind of a CPU here, and this CPU gives information according to the interaction of the fibrin and the patient's blood, and you get signature curves on this screen. So this is what is happening in ROTEM Delta, and this is what we have put in one of our theaters. ROTEM versus TEG. There is, I could go on and on in the differences. The difference is basically in the price cost. It is basically in the calibration. Anything new that comes on, an Apple 7 iPhone is much better than the Apple 4. So anything new technology coming on would cost more, but at the same time would give you faster result. These are all software gimmicks. It all depends on your institution, how you use it. Advantages of cheapness and cost effectiveness are there, but manual pipetting and electronic pipetting is what the ROTEM has done away with. The ROTEM Delta is also coming up in 2018. You'll see it at our SWAC ELSO conference. They're going to, for the first time in India, display it there. One works on a Linux software and the other works on, because ROTEM is working on a Linux software and not a Microsoft software, it is slightly more international and global. So the ROTEM is easier to use, the compliance is better. Tests finally are over in 15 minutes, and SonoClot is also very, very excellent for ECMO, and this is what we have done. TEG modifications of heparinase and tissue factor help the ECMO period. Why? Because we are using heparin, so heparinase is what should be done. A lot of controversy about what is the ideal anticoagulant during ECMO is on, and should we use TEG, but at the end of the day, the algorithm says XTEM and FIPTEM values. So the XTEM, FIPTEM values coming up from ELSO just mean that your ECMO patient should be on ROTEM. So this is what the Americans at ELSO are thinking. I'm sure the days are not far behind, where we also, not just like AIMS, but many other centers would be buying both the machines together. So 9 units of platelets that you give in a clinician-directed 30-patient group. This was a study done in 2001. You need to give only 1 unit in a TEG-directed group. So once you know that your blood product usage is less, the patient's attack by the blood products on the lungs is better, the patient is extubated from, weaned off from ECMO better, and this patient does better. So we all are very much aware that blood is very, very dangerous, and utility of TEG in ECMO has been studied so miraculously since the last decade. Linda Shore Hansen has done it, and the utility is absolutely good, especially when your patient is continuously bleeding on ECMO. But there is very good clinical evidence now in 2017 that TEG can direct and guide therapy and decrease blood product usage. And I have described if there is a residual heparin here, which is very common. This is the normal, this is residual heparin. So here your R and K were prolonged, and then after some time they became normal and your lysis 30 does not happen. So when lysis 30 is not happening, it means heparin effect is continuing. So if that is continuing, you start weaning off the heparin. So long R here shows there is a clotting factor deficiency. And if there is a clotting factor deficiency, then you see what is the factor which is deficient by seeing the MA and by seeing how the lysis 30 is happening. And the moment you put in this, the FLEV levels will come. If they are low, you know, invariably it is fibrinogen which is less when on ECMO. So these are some of the low MA. Low MA means it's a platelet dysfunction. Your patient here would need platelets and not fibrinogen. And once fibrinolysis sets in, here, this is also a low FibTem. This means lysis 30 is more than 10%. This means your patient here would only respond to fibrinogen or concentrate or cryo. So summary of use of TEG and ECMO is the causes of bleeding in a partial cardiopulmonary bypass like ECMO are very, very high, and platelet dysfunction is high, and heparin is there, and residual heparin effect stays on for a long time. Platelet dysfunction like thrombocytopenia, vitamin K deficiency, DIC, inherited hemostatic defects, systemic fibrinolysis, and protamine excess. When the patient is continuing to bleed, we have a tendency to keep giving protamine. That's something that tilts the balance and causes more bleeding. And when you see this, then a lot of studies done show that hypercoagulability by ROTEM and PFA 100. This is PFA 100 is a test which is another point of care test coming in. Hypocoagulability by routine coagulation and thrombus formation on the cannula. So a low molecular weight heparin is started. So TEG guides transfusion and medications during ECMO. So when you have a thrombus coming in, particularly at the cannula site or on the cannula, that's also a time to start low molecular weight heparin. So this is a lot of studies at AIIMS. Our experience with TEG, SonoClot and ROTEM, particularly in the last 2 years, has increased. We have been using thromboelastometry as a reliable point of care technique for most of our patients. Dr. Klaus from Germany, he is a part and parcel of SWAC ELSO, and he was over to give us a couple of lectures on ROTEM, and that's how we installed ROTEM. Simulation of ROTEM we used at that time to learn the process of ROTEM, which is advanced thromboelastography. And major bleeding is because of platelet aggregometry testing also possible on ROTEM, which gives us exactly how much of platelets to give. It's a very, very advanced platelet aggregometry, but ROTEM is the only machine so far which has separate platelet aggregometry for different reagents that we are using. It's more advanced. And as we use this, we also, with our systems, we also find so many chapters in our books. We've done SonoClot and tranexamic acid in so many of our patients. But the future is functional fibrinogen level. And this is something that is a big research project with us. This is from one of our patients. And if you see a value of 310 milligram per deciliter of a functional level of fibrinogen is on the higher side. And once that is high, you know in a minute, this according to the tangent, your MA is low, your lysis is not happening, your patient is having to need, because of low fibrinogen, a lot of cryo as well as fibrinogen concentrates. So this is how we are using on cyanotic patients and on our ECMO patients. We have taken FLEV with FibTem. Now here you can see this is the FibTem level. You can see this FibTem is low. You give 2 values of cryo, the FibTem improves. You give 4, it becomes even better. So this is how we use in our patient, one of our patients, we correlated the FibTem with XTEM, and this is where you can correlate fibrinogen at the common pathway and the extrinsic pathway of factor 10. You can see the MA is less, the R and K are slightly more, you give 2 cryo, both of them become normal simultaneously, FIPTEM as well as EXTEM. So INTEM and HEPTEM are related, and EXTEM and FIPTEM are related, and because FIPTEM is related, to see which is the best mark of fibrinogen level from the laboratory as such, which costs something like 12,000 rupees from a lab, which is not done routinely in most labs, or a FIPTEM which may cost something like 1200 and give you 2 cryos or 4 cryos and make the patient all right, or maybe of FLEV which costs just 900 and make you give 2 cryos or 4 cryos and make the patient all right. So cost effectiveness of these markers is being studied. I would like to end by saying that TEG provides near patient real-time dynamic measurements of coagulation as well as fibrinolysis. It is ideally designed to provide useful information amidst the cauldron of factors which contribute to post-cardiac ECMO surgical bleeding. The use of TEGMO to drive these patients is very cost effective and decreases the exposure to blood products, and appropriate use of TEG or its modifications or any point of care testing will give us very good outcomes of these ECMO courses, ECMO patients. I wish to announce and take this, you are in a center which is doing ECMO. They are the flying ECMO doctors of India. But we, before the launch of SWAC ELSO, we are having some pre-conference certificate courses and diploma courses. One such course is commencing. It's an online course. It's commencing on the 1st of July. And any one of you who's interested to learn and read more about ECMO, it's for a period of 3 months. You get a certification which is well accredited by the Delhi Medical Council, the ECMO Society, as well as the Simulation Society. And from USA, we have the International Society of Cardiovascular Ultrasound, which has pitched in. It would be provided to you on the digital hub of TCS as well as Bus for Health in the form of an app. So you'll have videos and lectures given to you on an online measurement. It comes at a cost, but it would help you, and our endeavor it is to make at least 600, 700 of you across the country very savvy towards ECMO before we come on in January at New Delhi. I invite you all, not just for the certificate course, but also to join us from 18 to 21st of January for the SWAC ELSO conference being held at AIIMS and Lee Meridian. So if we finish here, I would like to continue with my other talk. From AIIMS, I want to do this in one total so that you know that ECMO, ECHO and TEG or ROTAM or SonoClot should be bought together whenever you buy ECMO from your center. I'm not a commissioned person for any of the 3 machines, but I do research on them, and I feel patient safety outcomes have improved tremendously ever since we started to use them together. 2001, ECMO started at AIIMS. We were the first center in the country to start ECMO. We were the first center to start ECHO. We are not the first center to start any point of care testing. But at the same time, point of care testing is a more favorite with the liver transplant team. They cannot do a liver transplant without a point of care test. But having done cardiac transplants and having done ECMO, we realized we have so many cyanotic patients as well, that there's a need of the hour to use our blood products judiciously. And while we were doing so, the concept of ECHO in ECMO came up. And it's a very novel concept. While you are on ECMO, you use so many cannulas. If you see, this is the 2001 picture I have of a video. It started in my theater, and I'm very proud of it when we did our first ECMO at AIIMS. This is the centrifugal pump. We used a bladder, an ancient one at that time, our arterial and venous lines of the ECMO you're seeing. And we used to take away the machine, the whole machine of the centrifugal pump being used at that time, along with the patient while on ECMO. This is a VA ECMO being done in a patient for arterial switch operation. Now, developing on that concept in 2007 up to 2010, the cardiac surgeons and the anesthetists and the perfusionists of AIIMS did the concept of integrated ECMO, wherein if we decide that our patient has arterial switch operation with an intact D septum with a VSD, and there's a typical D of the LV, and the patient is more than 3 weeks, then we put the cannulas in the patient as we would do for an ECMO while on bypass, And when we come off the patient after the switch repair, we come off on the ECMO bypass, not the CPB bypass. So once you are doing something like that, you are saving time. You're doing it all under the surgeons are putting in the cannulas like they do for a CPB, for a corrective surgery, under all asepsis. So infections, bleeding, the time to set up an ECMO machine, the running here and there, all that ghabrat that happens and makes an ECMO fail because you waste time. All that is electively sort of, and you come out beautifully on an ECMO and you transfer the patient on one detachable. Our ECMO machines, CPB machines have a detachable pump, and the patient is weaned off from this ECMO and the pump within 5 to 6 hours. And we call this the integrated ECMO. So while we were doing this, our patient would collect a lot of blood. In the previous years, for a switch or any L-kappa or obstructive PVC, we would normally, in most of our cases, leave the chest open. So if the chest is open and covered with a pericardium or a blood bag, then there was a collection of blood. So how do you see the blood? The window is very bad for an echo. So we started the concept of putting in a TE probe, a pediatric or a neonatal TE probe, because that gives a better window than a transthoracic probe, even with the swabs or the things on the patient's chest. And to our surprise, we found that the blood clot is happening. Why? Because there is migration of the cannulas. This migration of the cannulas causes a left to right or a right to left shunt, and ECMO drainage decreases and ECMO fails. And within 5 to 8 to 10 hours or in 7 days time, the patient starts bleeding and ECMO failure happens. So while we were doing this, the concept of echo and ECMO came, and we know arterial ECMO circuits and we know venous. I won't go into this. Dr. Bartlett is the father of ECMO. You've been hearing that. But we started echo and ECMO for 5 major reasons. One of them was patient selection. The other was monitoring the ECMO support. The third was insertion and correct placement of the cannulas. The fourth was to detect complications during ECMO. And the last was to make a decision whether to wean off ECMO or not. And to wean off ECMO, you see a few things. Just as you wean off cardiopulmonary bypass, what is the right time for the trial of ECMO? So what is the best view? If all of you are well versed, there are 4 good views on TE or on transthoracic echo. One of them is that of a mid-papillary short axis view. This view, in the transgastric region, you put your TE probe forward. So you put your TE probe forward up to the stomach, and you retroflex your probe, and you see the ventricles, the 2 ventricles, kissing ventricles with the 2 papillary muscles. It means your patient is hypovolemic, which most of your ECMO patients are. You give volume to these patients and you adjust your ECMO flows according to the volume. You see the LV contract or retract, and I think Dr. Vivek showed it beautifully in one of his slides. And a poorly contractile myocardium needs inotropes. Short axis mid-papillary view, hypodynamic or a kissing ventricle or a kissing papillary muscle ventricle needs volume. A tamponading, a lot of collection of blood all around, needs pericardial synthesis. And a regional wall motion abnormality suggests the coming up of acute coronary syndrome in the form of a fresh infarction. And an increase in RA pressures tells you pulmonary embolism. So pulmonary embolism is very, very common, which leads to right ventricular dysfunction, which may appear, as Vivek told you, in the form of a pulmonary hemorrhage from the patient's, if the patient is intubated, from the patient's ET tube or from the mouth. So RV dysfunction happening during ECMO is very common, and all that you need to see is the status of the RA. And you see the cannulas, most of your ECMO cannulas in a V-ECMO lies on the RA. So you see the status of the RA, and you see whether the pressures of RA are rising or falling, and you rule out a pulmonary embolism. You see the LV and you see its contractility. You adjust your inotropes on ECMO. You see the regional wall motion abnormalities with akinesia, dyskinesia coming on. You know there is an inferior wall or an anterior lateral wall MI coming on, and you see blood collection with thickening of the pericardium and sluggish movement of both the ventricles. It means there's a cardiac tamponade. Correlated with your JVP pressures, correlated with your blood pressure, there is the Beck's triad, and you'll have a patient which is going to be needing immediate or an urgent pericardiocentesis even while on ECMO. So this is how echo helps. So while you are choosing your patients, echo is very important. Every patient does not deserve ECMO. You must rule it out. Rule out aortic dissection. So you do upper esophageal view or you do a long axis view. Every time while on ECMO, see three things: your LV function, your RV function. That's the first thing. See the opening and closing of your mitral valve and your aortic valve. These are important signs, because if your mitral valve is opening, see if it is opening with an MR or not. If there is a slight MR, is this worsening or not? A worsening MR means it is the impending ACS coming up. It is the beginning of an infarction. Your LV is not good. Aortic valve closing, as Vivek told you, is one of the worst signs. Aortic valve closing tells you what? It means that your LV is not pumping out. Yes, so LV stunning and stasis and thrombus formation will happen. And this is your patient requiring an urgent LV venting. So this is how echo helps you. You see three things, whether you see it in the mid-esophageal long axis view, or you see it in the form of an RA by seeing the bicaval view, the SVC as well as the IVC with the TR. That is the second view, which is important. The third view is for the fluid status, the transgastric mid-papillary short axis view. And the fourth view, which is also very important to tell you about the right side, is the lower esophageal hepatic vein view, which tells you about the IVC diameter, your RA pressures from the IVC diameter, and how your IVC and your hepatic vein are opening and how it is coming on into the RA. So these are some of the views. So first is rule out a dissection. Choose your patients well by ruling out AR, see the aortic valve. If there is an aortic valve regurgitation or a severe arterial vascular disease, your patient will not do very well on an ECMO. Do not put in an ECMO in such a patient. If there is a dissection in the form of a lumen, a false or a true lumen being seen, as you see it here, do not put an ECMO in such a patient. It is a relative contraindication. For a VV ECMO, a severe pulmonary hypertension is a big no. In that case, consider a VA ECMO in your patient instead of a VV ECMO. So when you're putting in a VV ECMO, rule out your increased or raised PA pressures and consider VA ECMO, and your patient will have cardiac failure. A VA ECMO is better. So this is one of the first views. You have to choose your patient well, rule out an AR, rule out a dissection in the aorta, see the bicaval. This is the bicaval view. This is your interatrial septum. This is your LA, this is your RA. So this is how the SVC is opening into the RA. Any cannula that you put into the internal jugular vein rests here. This is rule out an ASD. Any kind of an interatrial septal defect will cause you to have a left to right shunting. Any PFO, if it is present, tell the surgeon or the intensivist putting in the cannula. Why? Because your cannula from the right side will migrate through the PFO or ASD into the left side and cause a RA or a right to left or a left to right shunting, causing venous admixture, decreased cardiac output, and failure of ECMO. Then you have the IVC here. So the IVC here, and if you rotate it slightly towards 90 degrees, you have the tricuspid valve here. So you rule out a TR, see the SVC, whether it's blocked, open. SVC blocked, the cannula in place in the mid. Where should the cannula be? The cannula should be in the mid RA or towards the SVC. It should not be here. It should not migrate here. It should not migrate upwards. So this is the best view. This is the bicaval view. The other view here is the short axis aortic valve, mid-esophageal aortic valve short axis view, also called the Garland or the wraparound view. Now this view tells you about the aortic valve en-fas. This is the aortic valve. You can see the three cusps of the aortic valve. This is the RA, this is the RV, and you have the tricuspid valve here. And here you have the LA, and you have the RV outflow here. This is the position of the pulmonary valve. So you have the RV inflow with the tricuspid valve, the mid RV cavity, the RA cavity. This is the lower half of the interatrial septum, and you have the pulmonary valve with its outflow tract here. So is the pulmonary valve blocked? You can see the circumflex artery opening here. You can see the position of the coronaries here. Here is your RCA, here is your left circumflex or your left main, which divides into the LAD and the left circumflex upstairs. So those are the two views which are important. The third view, which is very, very important to rule out, is an ASD, an interatrial septal aneurysm, the presence of a PFO, a prominent Chiari network, and any pacemaker or ICD leads. So what happens in a Chiari network? You start having, in this Chiari network, you have the septal leaflets here. This Chiari network will cause an obstruction to your cannulas. So this is your septal and the posterior leaflet of the tricuspid valve. This is where in the RA the Chiari network will be. You can see the Chiari network here. So this will block any cannulas. So if there is a Chiari network, do not put in RA cannula, or do not preferably use ECMO at all. Then interatrial aneurysm, if it's septal aneurysm especially, this will grow in size as the ECMO is there. So do not use this as well. And while you're doing, rule out an ASD, a mid or a lower third or an upper third, a secundum, a primum, a PFO, any kind of ASD. A relative contraindication is do not put in an ECMO in such a patient. So this is how your echo before an ECMO helps you choose or rule out the advantage of an ECMO in selecting your patient. But once you've selected, your patient has no AR, no dissection, no Chiari network, no artifact at all in the RA, and no ASD PFO, and you've decided to continue on a VV or a VA ECMO. The intensivist or the surgeon goes ahead and puts the cannulas. So while you're inserting the cannulas, echo is something that directs this intensivist or surgeon as to where to put the cannulas best. And this is how the cannula will look like. This is the position of the cannula. So here we are at 100 degrees. Your TE probe is, this is the SVC, that's the interatrial septum. This is a very good position. It is both the wires as well as the cannula. Most of these cannulas are radiopaque, so you can see a good ultrasound or a TE window in this. So it is lying in a good position. Suppose this cannula was lying here, you would immediately see a jet, a turbulent ASD. Why? A shunting would have happened, the cannula would have migrated. So insert the cannulas. While you're inserting the cannulas, so far we were just doing repeated X-rays. We would see two things on an X-ray, the position of an access and a return cannula. Those are the two cannulas. One goes to the ECMO machine, the other brings back the oxygenated blood back to the patient. Now when you're putting in your access cannula, on an X-ray we were seeing, this is a VA ECMO, on an X-ray we were seeing that the access cannula through the left common femoral vein is slightly higher up, and the return cannula to the femoral artery is lower down. Now this is the normal position on an X-ray. You see the position of the cannulas on an X-ray. This is something similar. You can't see the femoral cannulas on an echo, but you can definitely see the position of your access cannula in an echo. So access cannulas, whether they are above or below the return cannula, the proximity of the two cannulas is a very bad situation. This is when the chattering happens. So keeping the cannula, the return and access cannula safe distance from each other is what echo helps you about. And you can use various views for this. You put the patient on an upper esophageal view, and here you can see this is the aorta. You can see it from the descending thoracic aorta. You can see in the upper ascending aorta the cannula has come up. So once you see the cannula in the upper part of the aorta from the descending thoracic aorta, it is in the mid-lumen. You'll tell the surgeon or the intensivist, my cannula is in the right position. This is in the descending thoracic aorta. This is in the upper ascending aorta. So see the position of the cannulas in different views and tell the surgeon whether the position is good or not. So ECMO complication of the malpositioning of the cannulas is something that is bad. So use 4 views for the cannula position. The best is bicable. A classical bicable at 30 to 60 degrees or a modified bicable at 90 to 110 degrees is the best view to tell you about the SVC, IVC cannula. The aortic cannulas, the descending thoracic aorta view or the upper esophageal short axis view is the best to tell you whether it is in the ascending aorta or the arch of aorta or just before the subclavian and in the descending thoracic aorta. So those are the 4 views for cannula positioning. Once you've seen the cannulas that they are in position, during maintenance of the ECMO, interatrial septum is something that you should keep seeing. In the mid-esophageal four-chamber view, even on a transthoracic echo, the parasternal view is the best view, or the xiphoid view on transthoracic echo is the best view to keep seeing the IAS. When you see the interatrial septum and you see it is intact, there's no turbulence in the RA or LA, it means, and you also keep seeing the coronary sinus. So many times the cannulas migrate into the coronary sinus. In fact, it is your duty to tell the intensivist before putting the cannula that there is no LSVC. LSVC is an enlarged coronary sinus, so it's a posterior structure. So you see the LSVC, rule out its sizing. If it is present, do not put in a cannula in the RA. Then you do a veno-venous femoral axis, that's better. Then across the tricuspid valve, see the worsening of the TR if it is there, and through a PFO into the LV. So many times, we just recently had an ECMO case where the cannula migrated from, we left a small PFO, and this was an integrated ECMO, and we found the cannula 2 days later into the LV, and the drainage of the ECMO was slowly coming down. So when you see something like this happening, do repeated echoes to see where your cannula position is. If it is in the LA or LV, it means the cannula has migrated, so do not put in a cannula. You'll have to pull out the cannula, or maybe have to do a surgical reconstruction. So when you put in an Avalon cannula, we know about the Avalon cannula, I'm sure you're listening about it so much. The blood here drains from the IVC and the SVC, and you have one lumen which allows the deoxygenated blood to drain from the IVC and the SVC, and you have a second lumen which allows the oxygenated blood within the same pipe to return the oxygenated blood towards the tricuspid valve. So when you have the Avalon cannula put in, always keep seeing the IAS and the tricuspid valve. The opening of this cannula towards, it should face the tricuspid valve. So keep seeing the tricuspid valve and the position so that this entity called recirculation does not set in. So when will recirculation set in? When you see the tricuspid regurg worsening or the mitral regurg worsening and the LV getting to be stunned, and you'll have a decrease in your cardiac output. When something like this is happening, be very, very careful it does not happen. So you keep doing an echo. The venous cannula should be positioned in the right atrium to allow the optimal blood flow into the circuit, and the peripheral arterial cannula, whatever we put in the femoral or the carotids, cannot be so well visualized. It could be visualized by an ultrasound machine, but not an echo machine. The imaging of the guide wire in the ascending aorta is very well visualized, and it can prevent malpositioning of the cannula. So this is the ascending aorta. This is a clip to show how the cannulas are being put in, and once they are being put in, we, if you can see on the right side panel, are continuously frozen on which view? Any one of you? Which view is this? You're seeing the aorta here, or is it the LA? So you're seeing the interatrial septum, you're seeing the cannula here. So you're seeing some turbulence around the cannula. While the cannula is being positioned, be in the bicaval view. This is the safest view to be in. There it has got stuck, it says stop. No? It's tired. So while we are putting in the cannulas, it is important that you maintain the cannula positioning by preventing malposition. And to prevent malposition, do not do an echo every day. Do not do it every hour, but do it once a day. The promise that we do is when a patient is not doing well, we do an echo in the morning and an echo in the evening to see the cannula position. So we close it and start again. It's hung. Yeah. While we do, I think any one of you wants a break, you can take a break, but I have 5 minutes more. That what happens to, I wanted to show a few videos. Can we close? Close completely.